السلام عليكم. محاضرتنا اليوم عن potassium homeostasis. In this lecture, we will know the role of the potassium in the body, how its level is regulated and maintained within the normal state, and what are the factors that regulate its level, or what are the organs that maintain the level of the potassium within the normal reference range. And also we will discuss the hypo and hyperkalemia and the causes of each of these conditions. Potassium is mainly found inside the cell, so it is major intracellular cation. The concentration of potassium inside the cell is about 20 times than its concentration outside the cell. So about 98% of 90% of potassium is found inside the cell, and 2% is found in the extracellular fluid. And this concentration, high concentration of potassium, is maintained inside the cell by the sodium-potassium ATPase, which is an active process, because the concentration of potassium is mainly inside the cell, while the concentration of the sodium is mainly outside the cell. And although the sodium can diffuse in small quantity to inside the cell, but this can be prevented by the sodium-potassium ATPase that maintain the concentration of sodium all outside the cell, or mainly outside the cell, and the potassium mainly inside the cell, because the continuous diffusion of sodium to inside the cell is associated with osmotic rupture of the cell. So this ATPase always maintain, it will exchange 3 sodium for outside the cell with 2 potassium to inside the cell. Why potassium is important in the body? Because it is very important for a proper neuromuscular excitability. It is very important for the contraction of the heart, for a normal intracellular fluid volume, for maintenance of hydrogen concentration within the normal range, and for the contraction of the cardiac and skeletal muscle. From these functions, we will notice that any change in the level of potassium, mean whether hypo or hyperkalemia, may affect the neuromuscular excitability, and we may get fatigue, the contraction of the heart, we may have arrhythmia, and there may be acidosis. It will also be linked with the alkalosis and acidosis, any abnormality in the potassium level. What are the factors that maintain the potassium concentration within the normal range, which is about 3.5 to 5.1 millimole per liter? It is very important to maintain the potassium within this range. So we have 3 main organs that are important in the maintenance of potassium within this range. First of all, we have the kidney. It is very important. We have the intestine, and we have the, because it is mainly about 98% found inside the cell, so the membrane of all other cells also are important to maintain the concentration of the potassium within the normal range. Because most of the potassium is found inside the cell, so when we measure the concentration of the potassium in the blood, whether blood or serum or plasma potassium, it doesn't accurately reflect the total potassium content of the body. Why? Because it is mainly found inside the cell, while when we measure the level of potassium, we measure the extracellular compartment, the potassium in the extracellular compartment. So the level of potassium in the circulation, in the blood, in the serum, or in the plasma does not really reflect the actual potassium level inside the body. This is the intracellular compartment, which is about 98% of the potassium. It is found in the cell, inside the cell, whether muscle or non-muscle cell. Also, we have a small quantity, which is about 2% of the total potassium, is found in the extracellular fluid, and this there will be exchange to maintain this potassium within the 2%. There will be exchange of the quantity and regulation of the amount between the kidney by the filtration and secretion and reabsorption, and the excess will be lost in the urine. And also in the muscle, there will be a release or uptake according to the state, different states. For example, after meal, after fasting, after exercise, all will change the quantity that will be exchanged. And also by the intestine, we have the intake, dietary intake of potassium. It will pass to the small intestine, and some will pass to the extracellular fluid, will be absorbed from the intestine, and the excess will be lost in a daily loss of about 5 milliequivalent or 5 millimole. So these are the most important organ to maintain the potassium homeostasis. First of all, we have the kidney. The glomerular filtrate contain large quantity of potassium, and it will be reabsorbed by the proximal tubule, nearly all of the filtered potassium. Then, after it is filtered and reabsorbed back to the body, there will be secretion of the potassium by the renal tubule into the lumen of the tubule by the effect of aldosterone, because aldosterone, it favors the reabsorption of sodium, and to maintain electroneutrality, aldosterone usually reabsorbs sodium for by exchange with another cation, which is either the potassium, or sometimes it exchange it with hydrogen. So after it is reabsorbed completely or nearly all of the filtered potassium in the proximal tubule, then by the effect of the aldosterone hormone in the distal tubule and collecting ducts, there will be secretion of some of the potassium into the luminal fluid. And this final adjustment will determine how much of the potassium will be secreted in the urine. So, how can we know how much potassium will be secreted in the urine? This depends on many factors. First of all, how much sodium is present in the fluid, because sodium in the renal fluid, in the tubular fluid, because potassium to be secreted in the tubular and the luminal fluid, it must be exchanged for sodium. So sodium must be available to be exchanged for it. Another factor is the aldosterone concentration, because this hormone, it will exchange sodium for potassium. So it favors the reabsorption of sodium and the excretion of potassium in the urine. And also the aldosterone, by its action, it will reabsorb sodium in exchange either for hydrogen or potassium. So the relative amount of hydrogen and potassium will determine in the collecting duct and distal tubular cells, will determine which one will be secreted in exchange for sodium. So we have three factors that control how much of the potassium will appear or secreted from the distal tubule cell and collecting duct cell into the urine. It depends first of all on the aldosterone that favor the reabsorption of the sodium in exchange for potassium, and depend on how much sodium is available for the exchange and how much, or the relative quantity of both hydrogen and potassium for the exchange. So the first controlling mechanism that maintain the potassium within the normal reference range is the kidney. The other important controlling mechanism is the membrane, the cell membrane. The concentration of the potassium inside the cell is about 20 times its concentration in the extracellular fluid, and this is maintained by an active process. It needs an transporter or pump, which is the sodium-potassium ATPase that is found on the cell surface. It will exchange two potassium to inside the cell and 3 sodium for outside the cell. If we have, for any cause, the plasma potassium increase, as a compensatory mechanism, the potassium will enter to inside the cell to normalize the potassium. And for any reason, if there is damage to the cell membrane, so for example, due to trauma or tumor lysis syndrome, whatever the cause that lead to damage to the cell membrane, this will lead to release of the 98% of the quantity of the potassium that's found inside the cell, and lead to increase in the concentration of the extracellular fluid, and which is normally 2%. So any cause, because the concentration of the potassium inside the cell is 20 times more than the extracellular fluid, if we have rupture of the cell membrane, this will lead to release of the potassium that's found inside the cell to the circulation and lead to hyperkalemia. So the cell membrane is very important to maintain the concentration of potassium within the normal range. If we have excessive amount of potassium in the circulation, it will enter the cell to normalize it. And if we have rupture of the cell for any cause, it will lead to release of potassium from inside the cell to the circulation. This is the cell. If we imagine that this is the cell, we will find that the potassium is written in capital and it's very large compared to the concentration of potassium which is outside the cell. What are the factors that favor the entry of potassium from outside the cell to the intracellular space? We have the insulin stimulate the entrance of potassium to inside the cell. We have the beta-2 stimulation in case of alkalosis. Also, it favors the entry of potassium to inside the cell, and the anabolism, when we in state of anabolism, it is need for intracellular important process, so it enhances the entry of potassium from outside the cell to inside the cell. On the contrary, we have a certain factor that favor the escape of the potassium from inside the cell to the outside. For example, in case of acidosis, we will find that the potassium will pass from inside the cell to the circulation, and one of the marker of diabetic ketoacidosis, for example, we will find that the patient will have hyperkalemia, which is a high level of potassium in the circulation, and this is because the potassium escape from inside the cell to the circulation. So in acidosis, for example, in diabetic ketoacidosis, we will find that the potassium is very high, and if we give him as a part of the treatment to diabetic patient, diabetic ketoacidosis, we start to give him insulin, we will find that the potassium will decrease in the circulation. This is because insulin will enhance the entry of potassium from the circulation to inside the cell. If we have increase in the tonicity of the extracellular fluid for any cause that increase the tonicity, for example, in the same example, in case of diabetes, also this will lead, or hypernatremia may lead to increase in the escape of potassium from the, or the diffusion from inside the cell to the outside. Beta blocker and alpha stimulation also stimulate the escape of potassium from inside the cell to the outside. Excessive severe exercise will lead to release of potassium from inside the cell to the circulation and lead to hyperkalemia in case severe exercise. And also we will have, in case of cell, if the cell membrane is damaged for any cause, it also will lead to release of the potassium from inside the cell to the circulation and result in this increase in the level of potassium. So, what are the factors that affect the distribution between of potassium between the intracellular compartment and the extracellular compartment? We are still in the second factor that will lead, or that control the potassium homeostasis, which is the cell membrane. The first one was the kidney. The second is the cell membrane. So, any factor that inhibit the pump sodium to outside the cell and potassium to inside the cell, for example, excessive digoxin, which is the drug used in heart disease, in case of low level of magnesium, in case of hypoxia, any of these that will lead to inhibition, and other cause, we have other causes than these, any cause that will lead to inhibition of the pump sodium continuously to outside the cell and potassium to inside the cell. If this will be inhibited, so we cannot maintain this concentration gradient, and the potassium the distribution will be disturbed. The second thing that favor is the insulin. It will enhance the entry of potassium into the cell, mainly of the skeletal muscle and the liver, by increasing the activity of the sodium-potassium ATPase. So if we have hypomagnesemia, hypoxia, or digoxin, it will inhibit the sodium-potassium ATPase and result in disturbance in the distribution and lead to a decrease in the pumping of potassium to inside the cell, while insulin enhance this pump, so allow the entrance of potassium to inside the cell, and the favorite distribution is of potassium 98% inside the cell, 2% outside the cell. The epinephrine, which is beta-2 stimulator, also promote the entry of potassium, allow or enhance the entry of potassium to inside the cell, while the beta blocker, for example, the Endiral, or the scientific name, the propranolol, enhance the entry of potassium to inside the cell. So we have the first factor, we have the kidney. The second factor, we have the cell membrane. We have certain things that enhance the entry of potassium to inside the cell by enhancing the activity of the pump that pump potassium to inside the cell, for example, the insulin, and the certain catecholamine like the epinephrine, and we have certain inhibitor of this pump that pump the potassium to inside the cell. For example, if we have digoxin overdose, if we have hypomagnesemia, hypoxia, all these will inhibit, and it will inhibit so potassium will not be pumped to inside the cell. The third factor that control the level of potassium to be within the normal range is the intestine. Potassium usually is found in the diet, and usually certain foods are rich in potassium. For example, the avocado, the fruit, especially the dried fruit, the nuts, the bran, the dried figs, the seaweed, all are rich in the potassium. Usually, there is daily urinary and fecal loss. So the dietary intake of potassium will replace the loss that take place daily in the urine or in the feces. And the site of absorption of the dietary potassium is in the small intestine. This is another figure. We will find that potassium mainly is found inside the cell. It is very important for the activity of the excitable tissue, the nerve, and we have internal balance and external balance. The external balance, we mean that depend on the amount that is ingested. So this GIT is very important as a source of potassium, and the excretion is usually by the renal system. It will be filtered in the glomerulus, which is the first part of the nephron. Most of it will be reabsorbed in the proximal convoluted tubule, then in the distal convoluted tubule and collecting duct. By the effect of aldosterone, it will be secreted, and the amount that is secreted depend on the level of the aldosterone, depend on the availability of the sodium, and the relative amount of sodium and hydrogen inside the cell. And the amount that will be lost in the renal will be compensated by the dietary intake. The internal potassium balance is that mainly potassium is found inside the cell. About 98% of potassium is inside the cell, and this will represent about 20 times the concentration inside the cell is more than the outside the cell. Certain factors favor the entrance of potassium inside the cell, and other factors will favor the escape of potassium from the cell. We have the insulin, alkalosis, and epinephrine favor the entrance of potassium to inside the cell, while the exercise, the damage to the cell membrane, the hyperosmolality, and the acidosis all will favor the escape of potassium from the intracellular compartment to the extracellular compartment, lead to hyperkalemia. So in this condition, we must put in our mind that to measure the plasma potassium in a regular way, especially in acidosis. Other factor that may play a role in maintenance of a level of potassium within the normal range is exercise. Enhance the release of potassium from the muscle cell, so it enhances the escape of but this will be transient and only for a few minutes, and after few minutes of rest they will return back to inside the cell. So if we want to measure the plasma potassium in a person, we must tell him not to do exercise during not to do the forearm exercise or excessive movement during the collection of the blood sample. Other factor is the hyperosmolality. Hyperosmolality, for any cause, will draw some water from the cell to outside to the extracellular fluid, and this water may carry with it potassium. So hyperosmolarity for any cause, for example, in case of diabetes and hyperglycemia, uncontrolled diabetes, we have hyperglycemia, it may carry potassium from the cell to outside the cell. Hypokalemia is a term used when the plasma potassium is below the normal lower limit of the reference range. Because the level of potassium is maintained through three important routes, either by the kidney, or by the GIT, or by the cell membrane shift, or we call it internal balance. So if we have decrease in the level of potassium, it means that the defect is one of these factors, either the kidney or the GIT, or there will be a shift from the intracellular compartment to the extracellular compartment. For example, one of the causes of the hypokalemia, in case the cause was in the GIT, excessive vomiting or excessive diarrhea or fistula in the GIT may lead to hypokalemia. Also, there will be sometimes excessive loss of potassium due to malabsorption. The absorption of potassium will be decreased, or when we have certain GIT tumor, or sometimes patients have chemotherapy or radiotherapy that decrease the absorption of the potassium from the intestine, and the potassium sometimes will be low, secondary to heavy intake of laxative. So, the GIT cause of hypokalemia may be due to vomiting, due to diarrhea, due to intestinal fistula, or gastric suction. Sometimes there will be excessive loss of potassium in the stool, secondary to certain GIT tumor or malabsorption, or secondary to the radiotherapy and chemotherapy that affect the ability of the intestine to absorb the potassium, or sometimes some patients are on a large dose of laxative that will lead to excessive loss of potassium, and eventually they end in hypokalemia. The renal loss of potassium may result from a certain type of nephritis that are potassium-losing nephritis, or a certain type of renal tubular acidosis that enhance the excretion of hydrogen, and potassium excretion will increase. In addition, any case of increase in the level of aldosterone, in case of hyperaldosteronism, also will lead to hypokalemia, because aldosterone favor the sodium retention and potassium loss. So any case of hyperaldosteronism can lead to hypokalemia and metabolic acidosis. Hypokalemia because it will be exchanged for sodium. Sometimes the excessive loss of hydrogen also will lead to metabolic alkalosis. So hypokalemia, if it's secondary to hyperaldosteronism, it will lead to metabolic alkalosis. Other cause is the hypomagnesemia, which is one of the cause of cellular exchange, or when there is a disorder in the internal balance of the potassium, when there is excessive escape of potassium from inside the cell to the outside the cell, when the sodium potassium ATPase is inhibited or the activity is decreased as a result of hypomagnesemia, for example, and also hypomagnesemia will enhance the renal loss of potassium and result in hypokalemia. Other factor that may lead to hypokalemia is the decrease in the intake. Decrease in the food that is rich in potassium also may lead to hypokalemia. What happens in patient with hypokalemia? He will complain from fatigue, weakness, constipation, and usually these became apparent when the concentration of potassium is below 3 milliequivalent or millimole per liter. Sometimes, if severe and prolonged decrease in the level of potassium, it will lead to a paralysis of the muscle of the respiratory system, and it will make the breathing difficult. And because it is very important for the excitability of the tissue, so the cardiovascular patient with cardiovascular disorder are more prone to have a more severe symptom of hypokalemia, and they will have arrhythmia and sometimes even sudden death. The other abnormality is the hyperkalemia. The hyperkalemia, also we will look for the controlling mechanism for potassium, and any disturbance in these mechanisms may lead to hyperkalemia. We know that the potassium is controlled either from the kidney, the GIT, or the internal balance by maintenance of the sodium ATPase that maintain the potassium inside the cell more than outside the cell. So, any cause of decreased renal excretion. For example, if we have renal failure, there will be retention of potassium inside the cell and inside the body, and would lead to hyperkalemia, whether acute or chronic renal failure. And also sometimes we have excessive intake, especially certain medication that contain high concentration of potassium, also will lead to hyperkalemia. The renal cause also, the mechanism is by impairment of the urine potassium excretion, and this will lead to hyperkalemia. In case of diabetes mellitus, also hyperkalemia may occur, because in case of diabetes there will be insulin deficiency that promote the cellular loss of potassium. It will inhibit the sodium potassium ATPase, and this will lead to escape of the potassium from inside the cell to outside, and also the hyperosmolarity caused by hyperglycemia. It will lead to this hyperosmolarity pull water from inside the cell, and it will pull the potassium with it. This will lead to more loss of potassium into the plasma. In case of metabolic acidosis, excess hydrogen will move intracellular to be buffered, and potassium will leave the cell to maintain electroneutrality. This is another cause, in addition to inhibition of the sodium potassium ATPase. Also, the hydrogen will pass to inside the cell, and hydrogen will pass inside the cell to be buffered and decrease the acidity of the blood, and on the expense of potassium that will move from inside the cell to the outside. So, in case of acute or chronic renal failure, when the GFR is less than 20 ml per minute, the potassium will be retained and lead to hyperkalemia. In case of hypoaldosteronism, favor the retention of sodium and the excretion of potassium to maintain the electroneutrality. In case there is a decrease in the level of aldosterone, the process of sodium retention and potassium excretion will be decreased, and as a result there will be hyperkalemia. In case of Addison disease, in which there will be decrease in the activity and synthesis of all of the adrenocortical hormone, including the corticosteroid and the mineralocorticoid, and this will lead to hyperkalemia. Use of certain diuretic that maintain the potassium inside the body also will lead to hyperkalemia. Cellular shift. In case of acidosis work by two mechanisms. Either it inhibits the sodium potassium ATPase, and this will lead to escape of potassium to outside the cell, and in addition the hydrogen, because of acidosis there will be excessive hydrogen in the circulation, and as a buffering mechanism it will try to move to inside the cell and to maintain the electroneutrality. Potassium, because both of them are positive charged, it will move to outside the cell to maintain the neutrality. In case of muscle injury or cellular injury, because the content and inside the cell is 20 times more than the outside the cell, so in this condition, when there is damage to the cell membrane, this will lead to release of large quantity of the intracellular potassium, leading to hyperkalemia. Chemotherapy also will lead to damage to the cell and release of large amount of potassium. Leukemia also. In case of hemolysis, in hemolysis there will be also release of large quantity of the potassium that's found inside the cell. This hemolysis may be due to anemia, or sometimes even when we take a blood sample and the sample is hemolyzed inside the collecting tube, this hemolysis may be due to pushing the blood sample vigorously, or sometimes the collecting tube is wet and it contains some drop of water. This will lead to a rupture of the cell and release of large quantity. This is artifactual, and we must put it in our mind that the cause of clenching, all these, the excessive fist clenching, sometimes some of the technician that ask you to before the blood collection, they ask you to fist clenching, which is a bad, and it is a bad technique, and it will lead to release of potassium from inside the cell. It will lead to false positive increase in the level of potassium, so this behavior must be avoided, or prolonged application of a tourniquet before collection of the blood sample also will lead to release of potassium from the cell, lead to false positive hyperkalemia. All these we call them artifactual, and we must put these finding in our mind before we interpret the level of high potassium in some patient, that the level of this high potassium is not fit with the clinical manifestation of the patient. The patient is healthy, but we found and you have no manifestation or sign and symptom of hyperkalemia, but the test result show hyperkalemia, so we put in our mind that these may be the cause. Sometimes excessive intake of potassium, either TAP or IV potassium replacement therapy more than the patient needs, also may lead to hyperkalemia. Also, it causes muscle weakness, it causes tingling, numbness, affect the mental cognition, it may lead to confusion, and sometimes if it is high enough, it may lead to arrhythmia because it disturbs the cardiac conduction. And if it's prolonged and high, it even may lead to cardiac arrest and death. So if the level is between 6 to 7 millimole per liter, the patient will show ECG change. And if the concentration is more than 10 milliequivalent per liter, it will lead to a fatal cardiac arrest. So we must be very careful when we interpret the result of potassium, and if we any condition that if we give any medication that increase the level of potassium, it is very necessary to maintain and measure the cardiac conduction by ECG regularly. How to assess the level of potassium? We have two samples that are good for measurement of potassium, the plasma potassium, and it is very important to use unhemolyzed venous sample. Unhemolyzed, why? Because if the cell RBC or white BC are hemolyzed, it will lead to release of the intracellular potassium and give a false positive high level of potassium. And also why it must be fresh? Because a prolonged if we make the sample, we collect the sample for a long period before we do analysis, this will lead to inhibition of the sodium potassium ATPase, and later on it will release of the potassium from inside the cell to the outside the cell, and lead to also false high level of potassium. Urine potassium is important to determine the cause of the low level of potassium. For example, if the plasma potassium show that the level of potassium is low, then we take a urine sample for measurement of potassium. If the concentration of potassium in the urine was less than 20 millimole per day, then the cause is not renal. It may be GIT, may be decreased intake, may be intracellular shift, but it is not renal. But if we have a hypokalemia in a plasma potassium sample and the potassium level in the urine is high, then it indicates that the cause of the deficiency of the potassium and the low level in the plasma potassium sample is due to renal cause. So renal may be very efficient in determining the cause of hypokalemia in the blood sample. If it is more than 20 millimole, it indicates renal cause, and if it is less, then it indicates it is a non-renal cause. It may be GIT, maybe decreased intake, or other causes, or sometimes intracellular shift. Another marker that may be useful in identifying the cause of hypokalemia is what is called the transtubular potassium gradient, the TTKG. This is an equation. We take a spot of urine and we measure the potassium and the osmolality in this blood, in this sample, and we take a plasma sample and we measure the potassium and the osmolality. Then by applying this equation, urine potassium multiplied by plasma osmolality divided by plasma potassium multiplied by the urine osmolality. In this case, if the result of this equation was less than 3, indicate that the kidney are not excreting enough potassium. So the measurement that are appropriate for knowing if there is deficiency or excess of potassium is the plasma potassium, and must be fresh sample, and the sample must be unhemolyzed. And then we measure the urine sample. If we found hypokalemia or any abnormality, we can define give a rough estimate whether the cause of the defect is in the renal or extrarenal mechanism, and then we do the transtubular potassium gradient, and this is we need in this to measure the plasma potassium and osmolality and the urine potassium and osmolality. So the summary of this lecture, the potassium homeostasis and its disorder are common, and it may be life-threatening. For example, it may lead to a paralysis of the respiratory muscle and lead to cardiac arrhythmia, which may be fatal sometimes if the abnormality in the level of potassium is severe. The other fact in this lecture is that the potassium is mainly intracellular cation. We said it's about 98% intracellular. So the plasma level of potassium do not adequately reflect the total potassium stores because only 2% of the potassium is found in the circulation. The potassium also is affected by renal excretion, which is increased by increase in the aldosterone. When there is a decrease in the blood volume and blood pressure, there is increase in the aldosterone. Any increase in aldosterone will favor and promote the retention of sodium and excretion of potassium. And the potassium also, the renal excretion of potassium is reduced by hydrogen. The cause of any abnormality of potassium, whether hypokalemia and or hyperkalemia, may lead to muscle weakness. In case of hypokalemia, paralytic ileus, ECG change. And the cause also reflects the main controlling mechanism, which is either the kidney or the GIT or cellular redistribution. The kidney in case of a certain diuretic, or there is potassium losing nephropathy, GIT loss of potassium in case of vomiting, diarrhea, fistula, in case of malabsorption, or in case of tumor or chemotherapy that affect, radiotherapy that affect the reabsorption, absorption of the potassium from the intestine, or it may be cellular redistribution. A certain factor enhance the escape of potassium from inside the cell to the extracellular fluid, or the vice versa. Sometimes the acidosis will lead to enhance the defect in the level of potassium. Hyperkalemia also is dangerous and also will lead to weakness and fatigue and lead to lethal cardiac arrhythmia if it is very high. And it may be also by the three mechanisms that control defect in any of the three mechanisms that control the level of potassium lead to abnormality in the level of its level in the plasma or the blood. For example, renal retention in case of acute or chronic renal failure lead to hyperkalemia. Movement out of the cell also will lead will disturb the internal balance of potassium. Increased intake, whether oral or IV, also will lead to hyperkalemia. Thank you.